Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. I am happy to be back with you after taking a break last week. Welcome to Open Mics with Dr. Stites. A woman wants to hear the words, "You have breast cancer." But imagine getting that news 5,000 miles from home. Dr. Silvia Byer is a professor at Park University here in Kansas City. While on vacation in Italy, she found a lump on her right breast and decided to get checked there by a doctor. As Janine Kiesling explains, Silvia returned to the United States with a cancer diagnosis and a lot of questions.
The diagnosis was certainly scary, but Dr. Silvia Byer says she was reassured because even in Italy, her doctors told her the best place to go for treatment is right down the road, back home.
I knew that I felt a lump, so a friend of mine suggested that I would go get it checked.
Silvia is a Park University professor with a PhD in Renaissance literature, and she loves teaching. Silvia wasn't too worried about the lump being cancerous, but her Italian doctors wanted a biopsy to be safe. Within a few days, she got the call. She had triple-negative breast cancer.
It was really a shock.
At 54, Silvia had always been active and healthy. Now she was scared, on vacation in another country, and had no idea what to do next. Fortunately, her Italian doctors knew just where to send her.
I was pleasantly surprised to know that right here at KU Med, we have one of the best investigators that are doing research specifically on triple-negative cancer. And I was elated to know that despite all this, I knew that I was going to be in great hands.
Silvia reached out to the University of Kansas Cancer Center immediately to get the ball rolling. From there, things happened quickly.
They knew that I was on my way, and so they saw me like 2 days after I landed. Basically, I was at KU. It was amazing, in fact, that it was so quick.
Within a week, Silvia started treatment. Her doctor, Priyanka Sharma, suggested a clinical trial of a new cancer-fighting drug called Keytruda.
I think I'll be happy to try, because what do I have to lose? Of course, I mean, everything to gain.
The drug worked and shrunk the cancer as doctors hoped. Silvia had surgery, then radiation, which started right before Christmas 2019. In February of 2020, Silvia finished her treatment and hasn't looked back.
What a great story. And we are pleased to have Dr. Silvia Byer with us right here in our own studio, and her physician, Dr. Priyanka Sharma, joining us remotely. Good morning to you both.
Good morning.
Thank you for being here.
Thank you for having me.
Well, it is is a delight, and you're very brave and courageous to come and tell your story here on the air. So, Silvia, let's start with you. What prompted you to check yourself in the first place, doing a breast exam while in Italy?
Well, you always try to, as you have to do your duty, to check yourself. And I kind of felt a lump there, and I was lucky enough to meet by chance a friend over coffee, and she told me, you need to have it checked. You have to absolutely check it right away. And she's the one that gave me the phone number, clinic to go, and I did. They got me in right away, and 10 days later, it was July 9th, 2019, I got the news, kind of in a very summative way. The radiologist told me, you have a very aggressive type of cancer, triple negative cancer, and it responds well to treatment. Just go back in the US, you're gonna have the wonderful surprise to find a great team of doctors, I'm sure of it. And I don't know, I was shocked. It was all at once. She just downloaded on me. I had no idea what triple negative meant. I had no idea that there were any type of different cancers for breast cancers. And so I learned a lot of things, but I was very naive. Who knows exactly, that you have different kinds of cancer within the breast if you're not in the medical field.
Right.
I'm in the literature field, so really that doesn't make, not many people talk about it either. So I think it is a good thing to know that, triple negative, it is a thing. And,
it is.
It does not respond, to other treatments, so it is very aggressive. You have no idea, naively, frankly, I have to say and disclose that, everything usually in the medical field, negative means actually a good thing, right?
Thing, yeah.
Especially now with COVID and all these infections, and you're positive, it's like you have the infection. You're negative, you don't have it. So I thought within myself, well, it's negative, it's going to be fine.
Well, that would have been a nice story, but
yeah.
So now you were on vacation in Italy, but Italy is really kind of a home for you.
Yes, it is home. It's my first home. That's where my family is, and I was visiting, and not that I just go home and have medical checkups, but yes, I was there, and luckily I knew where to go, and it was a surprise for everybody.
Yeah, that had to be hard, and I'm guessing this isn't something you normally study in the Renaissance literature part. Is that accurate?
Yes.
Yeah.
Yes.
Okay.
Yes. In fact, yeah. I was there for a conference also.
Yeah.
I was presenting a paper that kind of has nothing to do with anything, just.
Yeah, you were there for good reason.
Yes, I was.
So now, Dr. Sharma, talk to us a little bit about triple negative breast cancer. I think it's fairly uncommon, right?
Yeah, so triple negative breast cancer accounts for about 15% of all breast cancers. So if you look at the three major subtypes of breast cancer, this is the least common subtype. But as Silvia mentioned, it tends to be more aggressive and a little bit less curable than the other two subtypes. And it's kind of a paradox that it is negative, yet it has the worst outcomes, and we call it triple negative because it lacks the three common proteins that other cancers have, for which we have targeted drugs. And so all breast cancers that don't have those three common proteins get lumped into this basket of triple negative breast cancer. And it's primarily treated with chemotherapy, and in the last few years we've had the advent of immunotherapy to treat this type of breast cancer, which has actually made quite a significant amount of improvements in outcome.
So you're doing a lot of research on triple negative breast cancer, as I recall, and I've known, just in full disclosure, I've known Dr. Sharma for a few years, because I remember she was the chief resident for internal medicine, the training program, back when I was a program director. You haven't aged, I have. So, but tell us a little bit about what's the standard therapy for triple negative cancer, and how effective is it?
So the standard therapy is usually a combination of chemotherapy, drugs, and that was our standard for almost 2 decades, till about a couple of years ago when immunotherapy got added to our treatment algorithm and has made a difference in outcomes with improving the response rates and improving the cure rates from this type of cancer. It's typically an intense, long process of combination of chemotherapy and immunotherapy that's given together for about 5 to 6 months. And it is usually done before the surgery. Surgery follows, and for those that need radiation, radiation follows surgery. For some patients, there might be more treatment after radiation, including more immunotherapy and chemotherapy, and that's typically based on the response that we've seen with the initial chemoimmunotherapy. So when I saw Silvia, it was before immunotherapy was actually approved for this type of cancer. We were still testing it in clinical trials. And we had a trial here that was looking at a combination of chemotherapy plus immunotherapy that I was leading, that Silvia was gracious enough to participate in. And the unique thing about that trial was we were not only looking at the impact of immunotherapy, but we were also looking at a chemotherapy regimen that is less cumbersome to deliver. It is given less often and has drugs that don't have long-term toxicity. So from that aspect, it is beneficial in terms of long-term survivorship issues.
You know, it feels like these new trials in immunotherapy, and I think Keytruda is the drug she was treated with on the clinical trial. Immunotherapy is changing the face of cancer, isn't it?
Yes, so it's changing the face of many, many cancers. And, patients will often ask me, how does the immunotherapy work? And in some simple terms, what happens is the cancer is smart. Normally our immune system shouldn't let the cancer grow, right? These are foreign cells, but the cancer is smart. So it develops cloaks and proteins around it to evade the immune system. And what the immunotherapy does, it removes those cloaks and proteins from the cancer so the body's immune system can actually recognize cancer as foreign and attack it. So in some ways, it teaches the body to recognize the cancer as foreign again and help fight it. So it clearly has changed the landscape of many, many cancers in terms of improving outcomes, cure rates, improving survival. And there are many immunotherapy drugs that we have currently available for different types of cancers. For breast cancer, Keytruda or pembrolizumab is currently the only approved immunotherapy drug.
And it sounds like it's effective. I think that it compares really well against the old prior standard therapy.
So typically, in many cancers, the immunotherapy is added to chemotherapy. In some cancers, it's given by itself as a maintenance type of therapy. So in terms of, when we compare toxicities of some of our really old types of therapies, it compares favorably. These are tricky drugs, so as they teach the immune system to fight the cancer, sometimes they will teach the immune system to also fight self or the body. So some of the side effects that we see with immunotherapy are related to the immune system starting to attack itself or the body itself in addition to attacking the cancer. But we've been using these drugs now for quite some time, so the oncology community has a good handle on how to monitor for these side effects and how to treat them.
Yeah, that sounds like a really impressive thing. I remember growing up with the old drugs in cancer, and chemotherapy made people so darn sick. It feels like people do better with this combination or with even Keytruda alone. Is that fair?
Yes, and especially the combination that we studied in this trial didn't have the drugs that have the tremendous nausea associated with it or the long-term risks of leukemia or heart damage. So overall, it is a pretty effective combination and also safe in terms of long-term side effects for our patients.
So Dr. Byer, when we suggested to you or asked you about being in a clinical trial, what did you think?
I was really pleased. I was thinking about looking for a trial, and there it was. It was right here in the backyard of where I lived. And when Dr. Sharma proposed that to me, I really was pleased to be able to participate in it, because she explained exactly, how it works, and it helps your body fight the cancer, and the cancer cells are very smart. That's exactly, I remember that part. And it was weird to think that you have something inside of you that is attacking your own body, and then you have this super therapy that it will help your system fight it. and
is
it
remarkable.
did really well.
How soon did you see results?
You know, it was weird because I thought I was thinking things, and you know, you're wanting to be positive and have these positive thoughts because everything helps, right? At the same time, I had, and I felt that, you know, after probably three of these treatments, I felt my lump shrink, but I didn't want to say anything, and I was going in every week. But then it was, Dr. Sharma validated that, and it was really interesting because I was afraid. I was like, am I thinking things? Am I imagining things?
Is this too good to be
It
true?
was too
It's
good to be true. Is this
Yeah.
shrinking? So
Yeah.
much. It was really interesting to see how fast it was
worked.
working.
So, Dr. Sharma, is that a common story that Keytruda can work that fast?
So when we give it in combination with chemotherapy, often these drugs will start working within 6 to 8 weeks, and we can start appreciating the decrease in the tumor size, and often the patients will appreciate it even before we do, because you know they've been living with the tumor, and in about 6 out of 10 patients, when they go to surgery, it has worked so well that it has killed all active cells. And what we find at surgery is only a scar tissue, which is, the best outcome that we hope for when we give these combinations before surgery.
So it sounds like Keytruda is a remarkable drug. Has the FDA now approved it for the treatment of breast cancer and triple-negative breast cancer?
Yes, so it did get approved a couple of years after Silvia was participating in that trial. But during that period of time, clinical trials were the only way to access that drug. So now it is a routine drug that we use it for all eligible patients for triple-negative breast cancer, typically given alongside chemotherapy.
And just as a thought, I know patients, they come to a comprehensive cancer center, they can go into clinical trials. Could you have gotten this clinical trial at another, just a regular cancer care place for not really comprehensive, or is this something that's just through comprehensive cancer centers?
So this was actually our trial designed by us and supported by us. So it was only open here at KU and another site that we had solicited to participate with us. But it was not something that would have been available any place. And I have a lot of research infrastructure for triple-negative breast cancer. So we typically have 1 or 2 studies at least that we are conducting that is looking at better therapies or improving toxicities or tailoring therapy for patients with triple-negative breast cancer. And often there's something that is unique to our cancer center.
So Silvia, how long has it been since you finished treatment?
Oh, it's been 4 years.
Right there,
Yes.
Come on, that's
It's
awesome.
been really amazing.
That is, and I take it the status
really,
is good, you're in remission.
I'm in remission, yes, and it's been an amazing ride. I mean, it was, I'm not saying that it was not tough, of course, it was really tough. But knowing that you're in the right place, in the hands of Dr. Sharma, I have to say, and thank you. And knowing that it was working, and you can see and feel it, that the tumor is shrinking, it really is a positive outcome for everything.
So, Dr. Sharma, how is it important to have patients think about, maybe I should get a second opinion? How do you know when to and when not to?
So I think cancer is such a traumatic diagnosis, and the treatment that one receives is so important in terms of how patients going to do. I always tell my patients, you have to feel comfortable and confident in the opinion you get. And sometimes just having a second opinion validates what you already heard. Other times it gives you different perspectives or options for clinical trials to participate in. So patients should seek it out. And all of us, the oncology community, we embrace it with open arms, second opinions, either to see patients or if our patients want to go somewhere and get a second opinion. It's about the patient and their cancer and their outcome. And be advocates for yourself. That's what I tell my patients, be advocates for yourself.
I think that's right. You know, in my world, I'll see patients if I don't know the answer in CF or long-term. I'll make sure I get them into the right spot. Like, so this is who you need to go see. And the world for my area is small enough. This is where you need to go for this. This is where you need to go for that. And I send people out there all the time to say, this person knows more than I do. They're doing a clinical trial. Go check it out. And I think that's just the right thing to do if you're really going to be a patient advocate. And the physicians are offended by that. The problem's the physician, not the patient who needs to do that. Silvia, what's your advice for women like you who may have found a lump during a breast self-exam?
Well, excuse me. I think what I suggest is not only to have a mammogram and have it checked and then see what the results are of the mammogram, and depending on how your breast tissue is, also follow up with another type of test. Maybe a sonogram could be also something that, you know, may show something that the mammogram doesn't catch, which was in my case. So just, you know, second opinion is that, okay, you have a mammogram, not all the centers also follow up with the sonogram, but KU does. So that's another thing that I really suggest, that, you know, don't stop just there. If you know that there is a lump and they say it's like a cyst, continue your conversation with another doctor. That's where you have to go, seek other opinions.
Excellent advice. Thank you very much. So let's send us your questions. We're going to be here to answer those. Send us an email on YouTube, Facebook, the X platform, or email the Medical News Network. We'll get to those questions in just a moment. First, Hawk and I are going to talk a little bit. You know, Dr. Hawk, Infection Prevention and Control Director.
Yeah.
Our numbers from COVID have been pretty flat, Hawk.
They've been pretty flat. Again, not to where the peak of 22 active infections we were a few weeks ago. Right now we're at 16 active infections in the hospital. So again, that's good news. I was looking at the CDC website. Their most updated information is from data from November 4th. And at that point in time, they were seeing an overall decreasing trend for hospitalizations in the United States.
Which is great news.
Yeah.
And you know, I've seen so much COVID, I know you have in clinic and different family members in the community. There's still widespread transmission. The fact that there aren't as many people in hospitals as there were a year or two ago, that's a really good sign to me. You know, that's really good, because that's what we want. You know, we want less people coming in for this, having the risk of hospitalization and severe disease. Obviously, we know that those at greatest risk have the risk factors, especially age and other comorbid conditions like lung disease, heart disease, kidney disease, diabetes, and especially immunosuppression. You know, Hawkeye, you know, I've had many conversations about face masks, the importance. I think we spent a little time in the deep freeze to make a few pointers about that. Yeah. There was a new article published in JAMA Network on the open side of Open Network about reviewing face masking studies from the pandemic. Talk to us about that. And we know there's a lot of popular opinion out there for one reason or another saying masking doesn't work. I think, you know, just that black and white statement of masking doesn't work is really not catching the whole story. This was a special communication. It seemed like this was a meta-analysis, like you said, in JAMA Open Network. So a meta-analysis, they looked at many different studies and whether masking helps. And what they mean by this is really reducing the risk of transmission from the virus from one person to another. Now, randomized controlled trials we've always talked about, typically for most things are the gold standard. Not for everything. They did review 2 of the randomized controlled trials. One was in Denmark. Did not show statistically significant reduced transmission, but it did show a 20% reduced transmission for those people that wore masks as opposed to those people that did not. There were confounders to that. There was a Bangladesh study that was very well written and publicized. That was a randomized control trial. That absolutely showed that masking in situations did reduce the chance of transmission of that virus. And then most of the studies were observational. So they took one group looking at another group. Again, this is in real time, people living their real lives. So the randomized control trials are different and difficult to do. These observational studies are a little bit easier to do. One of them was done in our military in the U.S. Navy prior to vaccination, and that did show actually those people that wore masks on that ship in those small situations, in those small confined areas, did have a significant reduction in their risk of getting COVID-19 when they were masking. Yeah, it's funny. We're still fighting about it because there's really no question that it's low the risk of the COVID-19. Even here in Kansas, they did county studies looking at one county versus another county and finding a significant reduction in the counties that wear masks. Yeah. Observational studies are hard because you're just trying to say, hey, are people wearing masks or not wearing masks? How often are they wearing masks? Does that make a difference? Randomized controlled studies are clearly the gold standard, but it's very difficult to randomize people to do it and not to do it, and then to follow them longitudinally and see what their behaviors are actually like. So it's difficult to pull off. But there is so much science behind masking for so many generations. It is not a new concept. You walk into a hospital, we've been wearing masks for years, and I think the key to the public health emergency is it was just that. It was at a different time in the pandemic. People, and we were up to 250 patients. We couldn't take care of patients who had a heart attack and strokes because we had too many patients in hospital beds. There was no question that masking was the right thing to do. No question masking was the right thing to do at that time. This, however, is a different time, and I'm just so darn happy. The numbers are around 16 right now. Huh?
Yeah, no, absolutely, and it's not all or none. It's not black or white. There is a spectrum. And again, what we're trying to do is reduce the risk of transmission. And you know, because you have special populations of immunosuppressed people who are very susceptible to getting the disease, but also having severe outcomes. Your patients wear masks. And so that's what we are really looking to do, is help reduce your risk of transmission. Now, there are confounding factors such as good hand hygiene, understanding what kind of environment you're in and the engineering in that area. Are you really outside? Are you small confined spaces? So there are multiple factors involved, but certainly wearing masks, and one of the studies did show this, those people that wore masks, even in areas where people did not, still had reduced chance of getting the disease.
All right, Alexis Del Cid has been monitoring our feeds for your questions. Alexis, what are viewers asking us this morning?
Have a good question from one of our frequent flyers on Facebook, Yen Liang. He wants to know, is there any updated treatment for triple-negative breast cancer?
Dr. Sharma.
So the most recent updated addition to triple-negative breast cancer, as we talked about earlier, was immunotherapy. And the other new additions to treatment of advanced or metastatic triple-negative breast cancer is this class of drug called antibody-drug conjugates. There are two different antibody-drug conjugates that have been approved for treatment of triple-negative breast cancer. And these antibody-drug conjugates are what we call smart chemotherapies. These are chemotherapy that are attached to a certain protein that can latch onto actually the cancer cell and deliver the chemotherapy drug directly into the cancer cell. So even though these are chemotherapy drugs, these are smarter and more effective. So those are a couple of new additions. And of course, there's tremendous amount of research that's ongoing, looking at various new forms of treatment for this type of cancer.
Bob has a question. Bob writes, should every kind of cancer diagnosis have a second opinion?
So I think as we talked about earlier, it depends on the comfort level of the patient and their family, and of course what they have access to and the resources. I mean, in this era where we're able to offer telemedicine to at least some patients, some places give virtual opinions and chart review types of opinions, I think it's something that all patients should consider.
Do you ever have patients who are struggling with insurance? Because we've gotten a couple different questions on whether or not insurance will cover a second opinion. As long as the place that they're going to is in network and covered by the insurance, just because it is the second set of physicians the patient might be seeing, I haven't seen that being turned down. But again, I have to be honest, I don't handle that part as much. I focus on taking care of the patients when they arrive to clinic.
I think usually you have to go out and try and write a letter detailing for the reason for the second opinion. You can get second opinions paid for, but what you really have to do is demonstrate somebody has an expertise or ability that you don't have, and that therefore the insurance company needs to go ahead and pay that. Sometimes it's a little bit of a battle. You have to get a prior authorization to get it done.
Patrick has a question for Silvia. And Patrick wants to know, Silvia, first of all, how are you feeling as you sit here today, and what is the prognosis or the status of your health right now?
Today, I feel really well. I've been feeling well for the last 3 years, 4 years, maybe 3 years, and just recuperating. I am in remission. I don't have anything anymore. I'm not taking any medications. I've not been taking any medications for the last 3 years. So I do feel well, amazingly well. I mean, because it was not, while you're taking, all those treatments and you're doing those treatments, you're not feeling well. But
Right.
And Dr. Sharma, for a patient like Dr. Byer, what is the normal prognosis look like now?
So Silvia had her cancer had an excellent response. When she got to surgery, all the cancer was gone. We were left only with scar tissue. So that's the best outcome that we can hope for in that kind of situation. At about 3 to 4 years, the cure rate's over 95%. So, and the triple negative breast cancer, if it's going to come back, it would do so in the first 4 years first 5 years from diagnosis. So once you get beyond that point, that particular cancer no longer is a threat to an individual.
So when does she get to ring the bell?
exactly. Well, probably next year, I guess. I don't know.
Yeah, yes, or at the end of all treatment. So, at each time point or landmark is an achievement, right? You finish all the treatment, that's an achievement. You get to 2 years, that's an achievement. You get to 4 years, 5 years. I don't minimize any of those important landmarks. So I think the patients should ring the bell at all of those time points if that's what they wish to do.
Hey, the more bell ringing, the better. We love
Yes.
seeing that.
It is
we
the
have
right
one more-
season for it.
It is. It is, Dr. Stites. We have one more question from Mary. Mary wants to know if there were any side effects from the Keytruda.
On my end, no, there were no side effects. Actually,
Wow.
it was reducing, the amount of chemotherapy that I was being subjected to take. So that was the main thing. It was that I was being able to reduce the different chemotherapies, and Dr. Sharma can be more specific, but I think I was on 2 different chemotherapies instead of 4 because of the Keytruda. So that was amazing.
Yes.
So the side effect was you felt better? You didn't
Well,
feel as sick?
it still was a big change and a big impact. But probably if I had been, doing the standard of care that there was before instead of the Keytruda and this, it probably I would not have been able to lead a life. I mean, I was still, I did lose my hair, but and I had a few rough days. But then I was able to maintain the regular lifestyle. I kept working.
That's impressive. Well, this has been an awesome discussion. I am grateful to all of our guests for being here, but Dr. Byer, especially to you, to come
Thank
over
you,
there,
Dr.
as I
Stites.
say, and talk about this story about
Absolutely.
breast cancer is awesome. And we want the pictures when you're ringing the bell. We got to send those
okay,
over here.
sure.
We want to know about that.
We'll do that.
All right. So I'd like to get final thoughts from all of our guests here today before we go. Dr. Byer, let's start with you.
Well, thank you so much. Thank you very much for having me here, and it's been wonderful. And I'd be happy to, share any more of this journey that I have. Thank you so much.
I think it's inspirational. And Dr. Sharma, thanks for sharing too, and thanks for having such a great patient.
Oh, wonderful doctors.
Final thoughts.
I was going to just thank our patient community for endorsing and participating in research. And if it wasn't for their strength and bravery, we wouldn't find new treatments. So if it wasn't for patients like Silvia who took the chance, other patients after them wouldn't be able to benefit from newer treatments.
Doc Hawk.
Yeah, again, a great inspiring story. And in regards to infections, we know there's going to be quite a few right now. We are in the middle of respiratory viral season. Certainly continue those public health pillars, hand washing, don't touch your eyes, your nose, and your mouth. And of course, if you feel unsafe, it's always okay to wear a mask. That will help reduce the chance of you getting any one of those respiratory viral infections.
I'm always impressed on this program when we're able to talk about this intersection of faith, hope, and science. Having faith in your medical institutions and in yourself to take the leap to be a part of science brings hope to everybody. And it advances us and allows us to do things like Keytruda so we can change the face in the battle against triple-negative cancer. So thanks to everybody for being part of our program. And again, remember the intersection, faith, hope, and science. It's powerful. Be a part of that. We'll see you next time.
There is a strong connection between smoking and heart disease, even if you're not the one holding the cigarette. I'm Alexis Del Cid. On the next All Things Heart, we see firsthand the generational struggle of tackling this addiction, the damage to your heart every time you light up, and resources on how you can quit. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.